I'm Anne, and I'm an adult neurologist and also a clinician scientist, and I work at the Institute of Neurogenetics in Lubeck, which is in the north of Germany. I started working with dystonia actually when I was a medical student, which is now already, I think, more than 13 years ago. And I did my medical thesis, which is very common in Germany, that you do that during your studies. And I did a genetical analysis in a family which suffered from dystonia. And I was very fascinated by the disease, and this drove me also in the field of becoming a neurologist and to focus on movement disorders. So actually we treat every kind of dystonia, so different kind of dystonias like focal or segmental dystonia, but we also see patients with generalized dystonia. At the Institute of Neurogenetics, although we have a special interest in monogenic forms of dystonia. So really recently I, for example, finished a huge study in patients with DOPA-responsive dystonia due to mutations in the GCH1 gene. And as the name says, they're responsive to L-DOPA, so we also saw recently a huge group of these patients. For patients with focal dystonia, we treat them with botulinum neurotoxin treatment. For patients with generalized dystonia, we usually use oral pharmaceutical treatments like trihexyphenidyl, for example. Or for children with generalized dystonia, we always do a trial of L-DOPA at least to see if they respond, not to overlook DOPA-responsive dystonia. And then, of course, we also offer deep brain stimulation for patients, for example, who do not respond well to oral pharmaceutical treatment or intramuscular injections of botulinum neurotoxin. When we first see a patient where we suspect that this patient suffers from dystonia, you always want not to overlook a secondary dystonia, for example, due to brain damages or infections or trauma. So you would always do, for example, an MRI scan, and of course you do a broad history of the patient and also see if this dystonia maybe is also within the family, to know if you maybe should go more into genetic testing and counseling. And then we, of course, focus on the clinical picture the patient presents with. So where's the dystonia localized, and what are the main problems the dystonia patient has? So also this time that we need to really treat our patients well is quite individual. It depends, first of all, on the focus of the dystonia and also on the goals that the patient wants to achieve with the treatment. And also on the duration the patient has the disease. So I think what is important for us as clinicians is also to take time with the patient, to really take time to interview the patient well, to look at the patient in really close detail and to define together with the patient what are the major goals that should be achieved. And this can be time-consuming at the start, and especially to inform the patient that sometimes judging about a treatment shouldn't be done too early in the phase. So also the patient needs to take his or her time. So as a clinician scientist, I realized that our picture of dystonia changed from being at the start, being expected more a basal ganglia disorder only, but now we also know that all different kind of players within the motor network system are involved. So, for example, there can be subtypes of dystonia where the cerebellum plays a more important role than other neuronal system players. So I think the picture of dystonia really has changed in becoming a multi-network disorder. Dystonia is, I think, the fourth most common movement disorder, beside, for example, Parkinson's disease and essential tremor that are more common. And within the dystonias, I would say that focal dystonia in adulthood, that starts in adulthood, is the most common form of it. But for the different subtypes, we don't have really clear numbers. So I think we've come a long way already from dystonia at some decades ago being described as more only psychiatric, like hysteric disorder, and now knowing that it's really organic and that we have for some of the forms also identified genetic causes. And for the future, especially with at the Institute of Neurogenetics, with our interest in monogenic forms, we would like to establish these monogenic forms really as kind of model diseases for other dystonia forms that are so far not genetically well defined. I think in a lot of patients, psychiatric or psychological comorbidities or symptoms really make a major burden of the disease. And it also depends on the type of dystonia you have and of your story, of course. But I think there are some kinds of dystonia, including myoclonus dystonia, where the psychiatric symptoms are not only what we call reactive nature. So which means because you have the dystonia, these psychiatric symptoms appear. Because we also know of, for example, patients that have a mutation, or a dystonia gene mutation, but they don't show the motor symptoms, although they have psychiatric symptoms, which speaks also against a pure reactive nature of these psychiatric symptoms. So what I would recommend really is to have a doctor, for example, a family doctor that you really trust and that you see on a regular basis, that knows you and your story, and that is also referring you to a movement disorder specialist. So I think it's important to have both, and especially a movement disorder specialist clinic, which is internationally well connected and that knows what studies are going on in the field of your kind of dystonia and what could be maybe new treatments or maybe new clinical trials where you could, as a patient, participate if you want. So I think these two things are quite important. So receiving the David Marsden Award was an enormous honor for me. It was a surprise, and I was unbelievably happy because it really motivates me and the whole team at the Institute of Neurogenetics to push our research even forward. And so I'm unbelievably thankful to Dystonia Europe and the Dystonia Society, and especially to receive an award that is named after Professor Marsden is an tremendous honor to me, because he's one of the most brilliant movement disorder specialists of his generation. And so I'm unbelievably happy to be here today to participate at this really wonderful conference and to present our research and even to show you how we would like to follow up with the help of the award. This award is also really special because it's from a patient organization, and as a clinical researcher, I do research only in patients, and I'm unbelievably thankful for the patients to participate. And this award now also gives me the opportunity to present my research to the patients, and also to show them how we will use the award in the future is unbelievable, and I'm really, really thankful for that.